medical history. Fever for last 7 days associated with vomiting. 3 to 4 episodes of convulsion for last 2 days. Mother gives past history of respiratory distress, headache and bluish discoloration of the body during crying or feeding since early infancy. Known history of recurrent respiratory tract infection or hemoptysis. Developmental milestone delayed. History of immunization. The baby is immunized till date. No history of previous surgery or no history of ear discharge. In the physical examination, first I did the general survey. Pulse 120 per minute regular. Blood pressure 96 by 60 millimeter of mercury. Weight of the baby is 10 kilos. Height 78 centimeters. The child is thin. Temperature raised. Cyanosis present. Edema not present. Neck vein not engorged. Neckline not palpable. Oral hygiene is good. Next is systemic examination. First comes the CVS. On inspection there is bulge precordium. Palpation systolic thrill is felt over the left, third and fourth parasternal space. Apical impulse is felt 2 cm outside from the mid-clavicular line in left fourth intercostal space. Auscultation, hollow systolic murmur is felt is heard towards lower left sternal border. Respiratory examination, bilateral clear vesicular bed sound. CNS, the child is conscious and irritable. Liver and spleen not palpable. The investigation, hemoglobin 18 gram per dl, hematocrit 55%, total count 14,000 per cubic millimeter. Differential count, there is neutrophilic predominance. Chest X-ray is decreased bronchovascular marking, foot-shaped heart with apical shadow slightly upturned. Echocardiography found overriding of aorta, obstruction of the right ventricular outflow tract, size and continuity of the pulmonary artery. There is echo with color Doppler. We found the VSD and its flow, ejection fraction, and next the MRI of brain. Get multiple temporoparietal abscess. The multiple temporoparietal abscess probably due to congenital heart disease, tetralogy of Fallot.
So, can you explain why this child has cyanosis? You said in the first slide the parents are giving history of bluish discoloration.
The child has right to left side, so there is polycythemia.
Why cyanosis? So basically it is because of lot of deoxygenated hemoglobin. So what is the minimum hemoglobin you need for cyanosis to be manifest? So you said here the hemoglobin is 18 grams. So what is the saturation at which cyanosis will be seen depending on the hemoglobin? You have hemoglobin of 18, hemoglobin of 15, hemoglobin of 12, hemoglobin of 9. Is there a difference at the SpO2 which will manifest cyanosis between these, or is it the same? You understand the question? Will it be the same or different? It will be different. So higher the hemoglobin, at a higher SpO2 like 85 itself, cyanosis will be manifest. Lower the hemoglobin, your SpO2 has to fall something like 60 for cyanosis to be manifest. So it basically depends on the amount of reduced hemoglobin. You should know that. So that's why hemoglobin and cyanosis relation is important. Now why is there polycythemia in this child?
Because of hypoxia.
Give them the chance first.
Due to chronic hypoxia, there maybe activated cell that leads to polycythemia. More the hemoglobin, then more saturation will be there. The cyanosis will be there.
So because polycythemia is a compensation to hypoxia, to chronic hypoxia. Is there a problem for you as an anesthesiologist when you have polycythemia?
More viscosity is polycythemia, the blood is more viscous, and and the thromboembolic manifestation may be there.
Because it's more viscous and they can be prothrombotic. Any other problems because they're prothrombotic? Any other problem?
Increased risk of bleeding.
Yes. Why increased risk of bleeding is there?
Chance of coagulation along with DIC can also occur.
Exactly. Because of this prothrombotic tendency, there's more thrombi formation, so there's a consumption of coagulation factors. So whenever you have polycythemia, you have to also look for the presence of coagulopathy. Okay, this patient you said has tetralogy of Fallot. What are the 4 components of tetralogy?
Pulmonary stenosis or infundibular stenosis, overriding of aorta, PST, and right ventricular.
Right ventricular hypertrophy. So what are the factors determining the right to left shunt in this? Extent of infundibular stenosis and the size of your. So is there something called a pink tet? What is a pink tet?
And thirdly, tetralogy of Fallot with no cyanosis.
Why will you not have cyanosis if it's a tetralogy?
Pulmonary stenosis is not so severe.
Exactly. The infundibular stenosis is not very severe. So then the shunt will be left to right. Then you will not have cyanosis. That's what is called as a pink tet. Okay, so this patient is coming for a. Is there anything else?
I would rather like to see the history of TED specs. Anytime you talk about tetralogy of Fallot, you must talk about the frequency of TED spells and how long they last and how many times it happens. You should mention what is a TED spell.
The active declaration of hypoglycemia due to dying or feeding of the child. Because the patient is doing vascular resistance fall, there is intracardiac shunt, there is more intracardiac, more right to left shunt, causing hypoxia, hypercarbia, and acidosis. This more respiratory drive is more increased and more respiratory rate.
So how do you treat a TED spell?
First of all, 100% oxygen. Increase the SPR, we to increase the SPR.
100% oxygen increases the SPR. Can you increase oxygen saturation for shunts by just giving 100% oxygen? So is there any other important role of 100% oxygen in this?
Increases PVR.
Exactly. It decreases the pulmonary vascular resistance. Okay, 100% oxygen. Next. How does that help? Yes, okay. Okay. Is that why you're getting more morphine to decrease the rate of respiration? Yes, morphine helps in relieving the. But why does it help? Is it to do with the respiratory rate?
Reduce the sympathetic overactivity.
Yes, it just reduces the sympathetic tone. So your infundibular spasm comes down. Any other drugs to relax the infundibulum? Beta blockers can be given to relax. And also, you also have to give adequate hydration. That will be part. And if there is going to be metabolic acidosis, so as you're telling the treatment, you explain why this treatment is effective in managing the text. And that way, the examiner will understand that you understood the pathophysiology. Okay, tell us, this patient is coming for brain abscess drainage. So what do you want? How do you want to prepare? What is your anesthetic? What is your anesthetic cardiac grid?
First of all, we maintain the SBR. We avoid hypoxia.
So just tell me how this child has come now for emergency brain abscess drainage. So what are you going to do in your preoperative preparation, pre-medication, induction, maintenance, go like that?
So, just 1 minute. I couldn't see in your history about the GCS score of the child. how much alert the child is, whether the child is playing, whether the child is eating. The patient has a brain abscess. And to my surprise, the TLC is not elevated at all. With an abscess, go back to your investigations. So they're not telling them. See, just show me your TLC. It is 14,000 only, right? A brain abscess patient would be expected to have 30,000, 25,000 of TLC. And now all the stress cyanosis is present. What heart rate is 120, 2 years old? Is the patient is on beta blockers or not on beta blockers? And what is the temperature is raised? How much is the temperature? Is it a true case or? So those are the things which we need to look at. We need to know the general status of the patient as well. Whether the child is eating, drinking, what's the consciousness state. Patient has raised ICT. Is the patient having nausea, vomiting, any convulsions which have happened before? So all those things are which are very relevant to us to decide what we need to use or missing. Right? These patients can have convulsions. They can have febrile convulsions also. They can have increased nausea, vomiting also, raised ICT because of an intracranial abscess. They can have, right? You mentioned, and I'm sorry I missed it. So 3 episodes of convulsions. I missed that. What about the other things? Like the current general status, consciousness status, I mean what it is like, patient is on IV fluids, on orals, and so those things need to be covered up. What is the tone of the muscles? Is there rigidity? Is there clonus? Is there, really nerves? Is any one of them involved particularly? So we need to look at all the pupils, whether they are bilaterally equal, dilated, reacting. So this patient now has come for brain abscess drainage, right? So the patient has tetralogy of Fallot's. So how would you go about it? To pre-medicate, to accept, to fasting guidelines, everything you tell us.
You can allow fasting 2 hours, allow clear meal for 2 hours. I will pre-medicate by oral datum.
Patient who has raised ICT, patient who has had convulsions. That's what I was asking you, right? Would you give ketamine to those patients? You can go for midazolam and all other things, but ketamine to an extent should be avoided, especially in the younger age group. Although there are a couple of studies now telling us that even in raised ICT, ketamine is a good drug to be used. So, but those studies are very few. We cannot still take it for granted that we can use ketamine in such patients because we have had problems with ketamine when it is used with raised ICT.
Pre-medication, you decide on the general condition of the child. The child is already drowsy, then you don't need any pre-medicant at all. But if it's a fully awake, conscious, agitated child, then a pre-medicant will help. So that the general condition will tell you whether you need a pre-medication or not.
Child is irritated, so I will pre-medicate the child by giving nasal midazolam 0.1 to 0.2 milligram per day body weight. Then the patient child is taken to OT and first I will distribute the IV line and will induce the child with injection higher
Pre-medication.
atropine.
Before that, half an hour before surgery, this is a child with cyanotic congenital heart disease. Anything else has to be given? Antibiotics have to be given? No. Why? Is it necessary? Yes, it is. Infectoendocarditis prophylaxis. Say this child who is not a tetralogy of Fallot, I mean it's a TOF which has been prepared 2 months ago. Then would you give antibiotics? Why?
After a delay of 6 months when the needs were high, it is not
Why 6 months?
endothelialization.
So that area has to endothelialize, the repaired area. For that you need to give 6 months. Say this child had a blood toxic shunt placed. Will you then give? You will give. So you need to know what are the conditions under which you will have to give an IU prophylaxis before you give.
So you are given thiopentone and then suddenly the saturation from 85 drops to 60.
Here,
SVR has dropped, right? So the shunt has increased. So what will you do? So in these cases, when normally we use ketamine, but in these cases you should be using phenylephrine as more often after your drugs which will cause fall in SVR. So you will have to maintain your SVR at times with phenylephrine infusions. So you don't allow the SVR to fall and give phenylephrine infusion, you start it right in the beginning. So before induction, have the patient on phenylephrine infusion. Start with 100% oxygen so that the infundibular spasm and all is released. The RVOT is not dynamically obstructing, right? Start with phenylephrine infusions and then go ahead and induce the patient. Ketamine, of course, we will not be able to use. You will intubate? Yeah. So we will intubate the patient, get the tube in, and let them drain the abscess. What inhalational agents or what anesthetic management you will follow? What is the problem with sevoflurane?
Sevoflurane is like one max. Sevoflurane can also decrease the SVR.
What are the other problems with sevoflurane?
It increases agitation, but due to cerebral vascular
Specifically in patients with raised ICT, a child who is irritable, you will find that these patients will have an emergence phenomenon. They will be very irritable. At times they can throw convulsions also. So yes, the best of the lot is sevoflurane, but you will make sure that you are aware of these things which can happen. And if you want to prevent, you may have to give a small narcotic dose about 20 minutes before surgery so that the patient is not too agitated when you extubate the patient. And then you have to be very meticulous with your air bubbles and all those things. You will have to have a 3-way there to aspirate air when you inject so that no air embolism occurs. And all the time manage your SVR. That is the mainstay of what it is. Right? Try to manage your SVR, try to see that propranolol is given in the morning and you have a beta blocker which does not allow the heart rate to go up. These patients will have fever, so fever should be controlled because that is going to give you a heart rate 120, 140. So you may have to give some paracetamol to the patient or suppositories to get the fever down before you induce the patient. Get the heart rate down, make sure that the systemic inflammatory response is not there, which we always cannot be sure because the patient is having a cerebral abscess. So some amount of bacteremia would always be there. But just like Dr. Aruna said, you must give a broad spectrum antibiotic in the beginning itself. So that will take care of some of the cytokines and pro-inflammatory mediators which are there. And what about 18% of hemoglobin? Would you like to reduce it or would you like to continue with 18 grams? Not exchange transfusion. Hydration, you will overload a patient who is already having RBH.
I'll accept it. The normal model.
Yes, you can take out small amount, you can take out blood and see that the hemoglobin is reduced. So venting out of blood is possible. Some of them Lot of institutes, we also practice the same. If the hematocrit is high, and we try to bring down to the hemoglobin to less than 16. It's dangerous to have it more than 16 because the risk of hyperviscosity syndrome is high. So try to bring down that, and that may also help later on in the post-op period during the recovery. Right? So you can take out the blood, vent out the blood, and hydrate the patient. Yeah.
One more common question asked in any shunts is the speed of inhalation and intravenous induction. You need to know what happens. There's a left to right shunt, what happens to IV and inhalation induction. With the right to left shunt, what happens to IV and inhalation induction. Can you tell us?
Right to left shunt, will be slower. Slower induction and slower recovery.
Intravenous, like intravenous induction will be
Faster.
faster.
And the left to right shunt, reverse is done.
But it's not so clinically significant for a left to right shunt. And the other question will be, the delay is more for more soluble agents or for less soluble agents? It's more for the less soluble.